So, yes, I think I start right now. It's actually now 6:04. And first of all, good evening to everyone who is participating in this webinar. This will be about chest pain imaging algorithms and emergency radiology and the way how we are doing it in our institution. So my name is Ulf Teichgräber. I'm professor for radiology at the in University Hospital of Jena. This is in Thuringia, Germany, right in the middle of Germany, for those who are probably not so familiar. So somehow between Frankfurt and Leipzig, or Frankfurt and Berlin, halfway, so right in the heart of Germany. So we are large university hospital with 1,500 beds, and I want to introduce you how we are actually apply or use our CT scanner, especially for cardiovascular questions in emergency medicine, and how we elaborate this question. So let me just start with this topic. Actually, for the question and answers, just to make it more practical, I would ask you as participants to write your questions while I'm giving my presentation. This presentation is probably about 20 to 25 minutes, and then afterwards we will have plenty of time, and I will actually try to get back to all your questions you will ask me. So first of all, let's see how it works. Actually, my first webinar, so with the technical features, I'm a little bit struggling still, but I hope everything will goes well. We tested everything before, so I hope so that it works with you. And so here my conflict of interest, they are quite obvious, as I do also research, especially also on the topic of cardiac imaging. Well, first of all, I assume most of you are already GE CT users, so you're quite familiar with the possibilities, what your scanner technically is able to do. So I won't go so much into the technical details, more into the clinical application and also guidelines and how we could adapt the guidelines to our clinical practice as radiologists. So we know that with our latest generation of CT scanners, we are able to have fantastic coronary angiographies with CT, with low KKV gated chest CT angiography. I think this is nowadays already a standard, especially if you're using the latest technology. So an image acquisition time is usually less than a second of our imaging. So this is no more a question that we are technically able to do good imaging, but still there are plenty of different algorithms and settings we can use. And it's always a question which actually algorithm is the right one for our patient and in which situation we have to do this. And therefore I would like to show you a systematic approach how we are doing it in our hospital. So we actually introduced our CT Revolution scanner in January 2016, and it was more or less by accident that actually three things happened more or less in the same time period. So this is now 4 years ago. So we got a new cardiologist some month before. He came from New York City, and actually was the one who brought also some good new experience with him and also standards in terms of imaging to my hospital. But then even more important in Germany was that we got Professor Wilhelm Behringer. He's actually from Austria originally, and he is the first professor, the first full professorship of emergency medicine in Germany, whereas in many other European countries, emergency medicine is already a real discipline, and also on the university level, this is actually quite new in Germany, that we also assign professorship to this. So he was the very first one, and also originally he comes from internal medicine, and his research topic was the sudden heart death, and so this was quite nice with the interest of us to enforce and introduce the question of how we can do in acute care heart imaging and how to introduce that. Well, the emergency department already was quite active before Professor Behringer actually came. So we already had a CT scanner in our emergency department. This one was actually directly installed in the trauma room. So all major trauma patients anyway went to the CT scanner right away. It was only a minor use in terms of cardiac imaging. And the numbers before we installed the new scanner was already impressive. For our hospital, we had in the emergency department, we thought 33,000 patients. And in these patients, we had actually 3,300 patients with chest pain. This accounts for 400 patients with acute coronary syndromes. So these are the patients who actually more or less go right away to the by guidelines to the catheter to the cath lab. Whereas in the emergency department, we actually performed more than 17,000 CT scans already in 2015. We enlarged this number with the new scanner generation of the CT Revolution up to 24,000 examinations. And before we did already 700 CT scans for pulmonary embolism alone. These were non-gated examinations. This has actually completely changed. In the meantime, we are doing even more gated examinations than only for pulmonary embolism, and this is actually what is really new in the whole setting. So the most change we actually saw with the new generation of scanner that we are doing in the emergency medicine department for our acute patients, also gated CT examinations for the thorax. And this is really on clinical routine, which was before only an exception, and also took a long preparation for patients, and also the image quality was not acceptable for our referring physicians. So this is actually a view in our scanner room. It's a quite big room, probably a little bit different than most of your scanner rooms which you are used to. But this is actually also, you have always to consider, this is also our trauma room. We need the place for our patients in the trauma setting, and this one we actually adapted then also for our cardiac emergencies. This is the way of our console room, and as you can see, we have advanced workstation console right next to the PACS workstation console, and also a large imaging display. This is especially that all referring physicians, especially in trauma management, don't have to look at the small image while the, let's say, the radiologist is reconstructing the images and preparing them, so he can really follow the whole case. And especially for trauma management, this was actually invented or installed. And the same thing, the same setting we are using first of all for stroke management, as well as for the cardiac emergencies, which I show you in the following slides. Well, these are our main algorithms, which we actually introduced with our new scanner. So there's a triple rule out protocol where we look at coronaries, look for lung embolism and aortic dissection. And we actually only apply this for hemodynamically unstable patients where we are not sure what kind of situation we are facing. I go into the algorithms later on. And then we have so-called Big Five algorithm. This is mainly for our stroke management. This means brain perfusion, intracranial and extracranial arteries. Then we also image the aortic arch and also the left atrium and ventricle to see where's the source of the embolism. This is a special topic which I do not will discuss in this presentation here. But what we also established is an advanced coronary CT protocol where we are looking specifically for coronary artery diagnostics, which I discuss in the following. So, and what we did with our emergency physicians together is actually that we went through all these guidelines. And this was actually a work which took us nearly 2 years, and more or less we had to redo this in the beginning of this year, or actually over the summer, because most of the guidelines have been or new editions came out, especially for the pulmonary embolism. It was in this year, also for the coronary artery disease, which I will show you later in detail, and also for the acute pulmonary embolism. These were completely new this year. Main changes actually for us as radiologists are coming from the ESC guidelines for coronary artery disease, which I will explain to you later on. And but it's important that you go through these guidelines and you have to see how you really are able to adapt this to your clinical praxis. Not all guidelines request imaging so far, but definitely in the situations you have to know when to use what. So this is actually what came out after we established we looked at the guidelines and withdraw the informations which are in the clinical algorithms important for us to get to the right, to the appropriate CT algorithm. As you can see, here we have a patient history, the patient status. So when the patient comes in, hits the door of the emergency department, the physician has to decide if he is hemodynamically stable or unstable. Something which is actually, interestingly, in none of the guidelines really considered. But it's clinically the most important decision a physician has to make right in the beginning, because the workflow is completely different if you have someone stable or unstable. So for the unstable situation, the algorithm looks quite easy, and this is what I would like to show you before. So you have an unstable patient. There is no time in an unstable patient to look for biomarkers for laboratory results. You have to have a very quick imaging or diagnostic decision. And the most important part is, first of all, that you only have more or less 5 differential diagnoses. The one is the myocardial infarction, you have the pulmonary embolism, you have the acute aortic syndrome, that means aortic dissection or aortic rupture. You have tension, pneumothorax, and pericardial tamponade. These are 5 main situations which can evoke unstable situation of the patient. And the most important diagnostic instrument is by far not the CT. It's actually, the first one is the EKG. So if you have a STEMI, this patient has to go right away to the cath lab right here. So this algorithm is then very much straightforward. Let's see if I can show you this with my arrow. No, it's not working. Oh, there's the arrow. Sorry. Here you can see that, and the cath lab is the most important one. If there is actually no STEMI, then you have to do right away an ultrasound by guidelines. And the ultrasound is only there to look for pericard tamponade and pneumothorax. In clinical routine, we do this way, that we have the ultrasound unit right next to the CT scanner. So the time the patient is prepared for EKG, the scan for the ultrasound is already in preparation, so there is no real time loss. The whole thing for EKG and ultrasound should not take more than 1 to 2 minutes. And if this is actually ruled out, so you ruled out pericard tamponade and pneumothorax, then in this situation you are able to do a triple, or we call it more or less a dual rule out scan. It's actually a gated scan, but as we don't do this with a prepared patient with beta blocker, we are definitely not always able in these unstable patients to reconstruct the coronary arteries, but for the aortic disease, acute aortic disease or pulmonary embolism, we are able to do a confirmed diagnosis. In some patients, it's actually also possible to do a real triple rule out. That means reconstruct also from the image acquisition also the coronaries. But by definition, it's actually a dual rule out, because we can't confirm that we are able to do in all patients a triple rule out situation. This is the way how it looks like for our acute hemodynamic unstable patients. It's the same setup as you are used to it in your hospital for trauma patients, and everything is done on the CT scan, so the decision is really done also there the same way as you're dealing with a trauma patient. Well, this was quite easy workflow, and but it's much more complicated and sophisticated if you have a hemodynamic stable patient, because there you have to do a real risk assessment. Risk score assessment, I will go in detail about that, and also to look for biomarkers, because this is not time depending. But still, the best and the most important diagnostic tool in the beginning is again the EKG. Also here you have to rule out STEMI. If the STEMI is present, the patient goes right away to cath lab. So the same algorithm. If it is a non-STEMI by definition, other differential diagnoses are possible, and you can see we have a whole sort of diagnoses here, as you can see that, and it's much more sophisticated than you think, especially as a patient with chest pain can have different differential diagnosis, and makes it much more difficult for the decision making. And once you're clinically you ruled out a situation like pancreatitis or actually back pain, because most of these patients do not have, who are hitting the door of the emergency department with the diagnosis of chest pain, have definitely something else than probably cardiac or a pulmonary problem. There's something which you have to face in the situation. But once you have clinically the suspicion of one of these three main diagnoses of a pulmonary embolism, of a acute coronary syndrome or acute aortic syndromes, you are in the dilemma that you have to decide for one of the three protocols where I want to go in detail about. And you have the dedicated coronary CT protocol, which is here in black, meaning also that in these stable patients with no elevated enzymes and are mainly going for coronary heart disease and no acute acute coronary syndrome, you are really try to do then a real rule out of coronary heart disease, and the best thing is to do a coronary CT scan. But therefore you have to rule out also by pre-test probabilities that they have no pulmonary embolism and also no aortic syndrome, because you're concentrating your scan only on the coronaries. So the decision making is quite important for those patients. And therefore, we went the way that we established this software tool, which is actually designed to look mainly on the pretest probabilities. And the pretest probabilities on the one hand side, let's see, we have the arrow again, one hand side for the acute coronary syndrome, and there you're looking for the troponin at admission to the hospital, and if this is in the normal values, you have to repeat this after 3 hours. And if it is then below 20% of the first value you had at the admission time, then it's you definitely have ruled out by guidelines acute coronary syndrome. And if you then also know the sex of the patient and also the age of the patient, you're able to calculate the Diamond-Forrester score. And this is something which this software tool is doing automatically for you, and then it's easy. And then afterwards, it gives you a recommendation what kind of scan has to be done. In the meantime, in parallel, this software tool allows you to calculate for the WELL score and PERC score. These are a couple or some questions, clinical questions on the patient's probability of having pulmonary embolism. The same thing is also, there is a AAS score, acute aortic syndrome score, which you can use. And this is something which then also relies on the didymers, and all these informations the physician is actually more or less punching in the computer, or the computer gets the laboratory results automatically from the lab. And so it really gives them, the physician and us as radiologists, pre-test probability and also a suggestion of what kind of imaging has to result. In addition, for the physician, quite important is it gives them the gray score, the hard score, the TIMI score, which is important for their decision making clinically. So this is the way how we actually proceed beforehand, before we actually decide on what kind of imaging we are doing on our patients. So here I go for one example with a patient with which came in as with a question of acute coronary syndrome, but actually we were able by troponin level to rule out an cardiac infarction, and therefore we have a male patient with 46 years old with sustained chest pain and exertion at rest. And relief, and there was no relief with at rest or with nitron, and though we calculated a pretest probability in this case of 38%, so that means he has an intermediate probability for a coronary artery disease. So in this case, you might decide then to go for a cardiac scan. Well, this algorithm is actually what I've shown you in the briefly before, is actually what you find back in this algorithm. This algorithm comes directly from the guidelines, from the old guidelines, I have to say, the previous guidelines from coronary artery disease. And you see that especially here, if you have an unstable angina pectoris, so a chest pain patient, and the question of instability, and if you have a stable patient, then you look at the pretest probability, and in our case, with 38% of pretest probability, the decision tree would guide you directly to the coronary CT. This was actually true for our guidelines so far. up to 50% of pretest probability. And actually, this is the only way where actually a CT scan was recommended by guidelines until the summer. You see on the right, the red bar. These are the patients who have acute coronary syndrome, so a so-called NSTEMI with elevated troponin levels, for example, or unstable angina pectoris. And these patients are those who usually go to the chest pain unit, and were not recommended so far, even by the new guidelines for imaging, for non-invasive imaging so far. But we don't know. There were a lot of changes this year regarding the stable chest pain patients in terms of a change of pretest probability. And this is something I really want to show you right in the next slides, because there was a tremendous change. I start now, first of all, with the guidelines of 2012 of the American Heart Association. They followed the same recommendations in terms of how they defined a typical angina, atypical non-anginal pain, by actually, I take the arrow again. Where's it? That's down here. And also by precordial pressure, and so precordial pain, and increase of symptoms under stress, and then the decrease of symptoms in rest or with nitrogen uptake. And if you have only one symptoms of the three, you're a non-anginal pain. If you have two symptoms, you're atypical. And if you have all three symptoms, you're typical angina. And as you can see, they do the recommendation between 15% and 85% in pretest probability to go for non-invasive imaging such as CT. And this is something which is then also important, because there in the US you already could, since more or less 7 years, to evaluate your patient non-invasively also in the emergency room, because you include most of the patients depending on age and sex within this guidelines. But if you look now at the European guidelines so far, the 2013 guidelines, the ESC guidelines, only allowed us to, or recommended us to scan patients with 15 to 50% and non-invasively. And you see the amount of patient the patients we are addressing is quite limited. And especially for very low pretest probability, below 50%, these were non-anginal pain patients, mostly women and men, and also the elderly patients here. And those who are really at risk of having coronary artery disease, where it makes really sense to scan them non-invasively. These are the typical angina patients, which are those we have to do with in the emergency department mainly. These were not included. But this has actually completely changed with the new guidelines. And all this, what I've now shown you is now history since 3 months, because the new ESC guidelines, which were already announced last year, but now came out not even 3 months ago. I think since 12 weeks we do have them officially. And what has actually changed? There are many changes in this new guidelines. I only want to focus on the prevalence of the coronary artery disease. Now also this term has completely changed. It's now coronary heart disease, or CHD, because the new guidelines say, well, those patients do not only have to have the situation that they have a stenotic artery disease. There are also other sources or etiologies which can cause chronic heart disease. So they have a new name for it for the guidelines. So it's now called chronic heart disease. But actually, for us, it's more or less the same. It's if you know now say CHD or CAD, it's meant the same. So if you hear now both terms, it's actually equivalent. And this is actually the prevalence of CAD in the symptomatic population is completely decreased, leading to lower pretest probabilities. That means the old Diamond Forrester data came from the 70s. In the 70s, well, the incidence of CAD was much higher in the population. Which was actually mainly due to the fact that we had probably much more smokers at the time, and probably also, but this is only an assumption, that people are now also living a little bit healthier than probably in the 70s. I'm not sure about this fact, but but the fact is that the pretest probability for having a CAD is really dramatically changed, and we can see this in many clinical trials that this is really also true, and therefore also the guidelines have changed. Significant advantages in imaging, anatomy and function can be therefore measured from now on non-invasively, and also we have a lot of innovations in imaging quality. This also leads to the point that the new guidelines really recommend right away with low pretest probability to go right away for non-invasive imaging. I don't want to go into detail of the underlying studies due to the time, but actually the whole workflow for the coronary artery disease has completely changed. As you can see here, we have now a workflow which starts in the guideline, and this was not the way before in the old guidelines, that we start with the symptoms and clinical investigations. So the decision tree has to be done. Is it a non-stable or a stable angina, angina? If it's a stable angina, we have to, the physician has to look for comorbidities and quality of life. And after that has to follow the resting EKG, the biomarkers, also still a chest X-ray is recommended, but only in selected patients. So you can also leave this out. And then, of course, the EKG at rest is very important. And all these informations you now take to calculate your pre-test probability, which we actually in our institution did since 2016 with our software evaluation. And therefore, you have then a good estimate of the clinical likelihood of having a coronary artery disease. This also leads us to this decision, which makes if the pretest probability is relatively low, you are more or less recommended to go for non-invasive further diagnostic. The higher the pretest probability is, and actually, as I mentioned before, it is mostly in all patients lower than it was estimated before. That means only in those who have a very high probability, further invasive angiography is recommended by the guidelines. And you have to see these are cardiology guidelines, these are not radiology guidelines. So this is something like a paradigm shift in the whole imaging of our patients. So this is something you have always to keep in mind behind that, because all patients you are seeing here where you have ruled out definitely have ruled out a patient with acute coronary syndromes by troponin level is not elevated. Those patients you should then, those patients by definition have a low pretest probability of having a coronary artery disease, and therefore should also be eligible for non-invasive imaging. And this is the way how the pretest probability table looks like today in the new guidelines. And as you see here, everything is more or less yellow, green, and green. This means we have to rule out, meaning that we can rule out the coronary heart disease with non-invasive imaging. And for us, especially in the emergency setting, the best way and the easiest is to do this with CT scan nowadays, because we are able to provide good quality imaging right away and give also a decision making right in the emergency department without referring the patient somewhere else. And this is something which has completely changed the world for us since this time, so that since especially for us, we already did a lot of acute scanning before in the emergency department, but now it's nearly coming as often as probably our rule out for pulmonary embolism and rule out CAD is probably the same incidence, which has now completely changed only by the fact that the pretest probability is now much lower in the guidelines. And also the interest of our cardiologists is so much higher to use CT for rule out coronary artery disease than before. And this is also a very important slide, because this really shows you the pretest probabilities for ruling out and ruling in. So what does it mean? Actually, the pretest probability where negative, the range of pretest probability range where a negative test can rule out coronary artery disease as post-test probability will drop as shown here. And for example, if we now look for the stress EKG, so everything which is green here now tries to rule out, is possible to rule out the CAD, the coronary heart disease. And as you can see here, it's between 0 and 5% where it is green. That means for most pretest probabilities, it's gray. That means it has no value. And only if the patient is really extremely ill, so that you have to with a very high pretest probability. And these are nowadays those patients only who have also elevated troponin levels already, because it's a pretest probability is here by 100%. We do not talk anymore about a stable angina patient, though therefore probably also it is possible with a stress EKG to rule in patients. And so this test by pretest probability is really nonsense. So it's still somewhere in the guidelines, but it has no more actually the value as it was many years before. And we know by pretest probability is really a useless test. Whereas CT angiography is now, as you can see here, the green bar is really going far beyond and up to nearly 85% of pretest probability. And as you know from the Diamond Forrester scheme in the new guidelines, it's completely dropped, so that you have most of the patients, the highest you have in the pretest probability was 54%. That means, I go back with the slide so that you can see this again. The highest is now with typical angina, 70 years plus, a male is 52% of pretest probability. This is the highest you can have. So that means you can rule in every patient you're seeing in the emergency department or in the cardiology department who has ruled, where they already ruled out the acute coronary syndrome. So nearly every patient is now recommended to get non-invasive CT, and the best test you can do is really, as compared to most others, is actually CT angiography according to pretest probabilities to rule in as well as to rule out a disease. So the overlap is here quite well. You have some difficulties to rule in and out in terms of sensitivity and specificity in high probabilities, but these probabilities in reality you do not see anymore. The next best test is the PET scan, but it's not that easy available. But as you can see, it's only to rule out a disease. It's probably a little bit better than CT, but to rule in, it's actually weaker as test than the CT angiography. The same is for the stress MRI. The stress MRI and inspect is much more or less reliable than the CTA. And if you now combine the CT with the fractional flow reserve, so with the functional test, you see that actually the results are not getting better, than are getting worse. You might ask, how could this be? I have now additional information like fractional flow reserve, or let's say a perfusion imaging as additional tests. But you have to see that all these pre-test probabilities are adapted to the results of the gold standard. And the gold standard is actually the invasive coronary angiography. And as a coronary angiography itself as gold standard has also its limitations and also its pre-test and post-test probability. Therefore, it's actually also the question if this is really so valuable. So also the nowadays we really have to ask ourselves, what is actually the real gold standard? For nearly now three decades, it was coronary angiography, the invasive coronary angiography. But now coming with the new technology and with what we nowadays can do with CT angiography in future, studies will definitely show that probably even we are in CT angiography probably better than the still, let's say, gold standard in coronary angiography. But this will be shown in future, but still with this, what we have today, that we have a very high sensitivity with CT and also have the possibility to scan nearly all patients. So this was just important for, I think, as introduction. So you don't have to have restrictions anymore. And this is my first take-home message in terms of pre-test probability that if you're non-invasively approaching your patient with coronary artery disease. But we are often facing also situations where we do not really know, does he really have a coronary artery disease, or is it probably still an emergency patient, also the pulmonary embolism with a high pre-test probability, and perhaps also acute aortic syndrome. Therefore, still we believe that the triple rule out protocol has a certain value. And especially with the new technique, we are also able to provide this in a reasonable quality. Therefore, you have to adapt your program a little bit. We take the big block, are 2 times 16 centimeters as actual scan. We scan not from toes up, but from head down. Sorry, I have just a helicopter coming here. I just close the window. Sorry about that. And then using the same, more or less the same protocol as we use for the coronaries, but with a wide window acquisition with CT gating and KV assist, which is then adapted to the BMI. And here we go for a little bit higher volume of contrast with 18 milliliters or 70 milliliters with 4 milliliters per second as speed to get also a good contrast of all our pulmonary and also a runoff of our aortic aorta in the abdomen if necessary. And so we take a little bit more of contrast, where we, with pure coronary scan, we can end up with 40 to 50 milliliters of contrast. And of course, bolo tracking, I think this is nowadays anyhow standard. We don't have to discuss that. So let me just show you one of our first cases We have a 65-year-old patient with a sharp left-sided chest pain radiating in the shoulder, hypertensive crisis, and also negative sensitivity or negative troponin level. And in the EKG, we had actually left LT and SR decrease and the decrease ST depression in lead 2, V3 and 4, and the didymers were positive. So in this case, we decided to go for a triple rule out protocol with no administration of a beta blocker, because we had not the time really to prepare the patient anymore, and we're not sure if he's hemodynamically so stable that we could really go for nitroglycerin and beta blocker together. So we just did the scan as if we do a rule out pulmonary embolism, and this is the quality we actually acquired in this patient. And there was actually in the reconstructions and also a mild stenosis of the LAD. The finding was also confirmed in the coronary angiography, and there was no intervention needed in this patient. And we also ruled out in the same patient the pulmonary embolism as well as the aortic syndrome. So this was possible to do this in one patient. The second case, we had a 63-year-old female patient presenting in the ER with progressive weakening in the legs and dyspnea since about 2 months, presenting with thoracic pain. We have here a positive troponin. The didymers were elevated, and also myoglobin were elevated. Also in this patient, we decided on doing triple rule out protocol the same way that we did no administration of beta blocker and nitroglycerin. And as I mentioned before in the beginning, here my slides, I show this as a triple rule out protocol, but we define this in our emergency department to our physicians always as dual rule out protocol, because we don't give the assurance that we are always able to reconstruct the coronaries. And this is, in our experience with our new protocols, possible, let's say, in 80% of our patients where we do our triple rule out protocol, but we do not have 100%, because if the heart rate is too high, let's say higher than 100, and we have arrhythmia, still we have the risk that we are not able, even if we are doing the full cycle or multi-phase acquisition, that we are always able to reconstruct the coronaries accordingly. But mostly it works quite well, as in this case here. And you can see already here in the that we have a lot of calcium right here in the coronaries. And if you do the reconstruction right here in this case, you're also able to see some calcification, but you see no stenotic lesions, neither in the RCA, which is also quite nicely reconstructed. The same for the LAD and the LCX. So in this case, there was no aortic dissection, and there were some wall irregularities of the right coronary arteries, and no significant stenosis diagnosis was then also confirmed in the cath lab, because those patients still have to go after the guidelines where we ruled out, which primarily were the decision for acute aortic syndromes. By guidelines, you have to send them to the cath lab. But in our experience, I think in future we are no more able able, no more necessary to do that from clinical praxis. By guidelines, yes, but by clinical praxis with this image quality, I think it's no more necessary to send them to the cath lab, because we can rely on these images also with a triple or so-called dual rule-out protocol. What you see down here is actually the little nice, neat software option which GE offers us as a plug ID. The plug ID is just making a color coding of your plugs and your arterial wall of the coronaries, and which is here in purple is actually more a soft plug, and which is yellow is then a calcified plug. And if it's blue or bluish, then it's more fat. So this is actually very easy to determine, and you can also give them some more information to your cardiologist. Nowadays, also plug morphology plays a bigger role, such as vulnerable plug, and in these questions. I don't go in depth into this issue here, but it's very important point of view for the cardiologist nowadays, especially to characterize the plug by itself. And this information you can have right away with this plug ID. I don't know how much your experience is so far with this, but I think this is quite helpful. And so we do this always in addition to our cardiac scan. So in this case, as I mentioned, there was no aortic dissection, but we had diagnosed the aneurysm of the left atrium, which we have right here. This is something which definitely has to be discussed with your cardiologist, and in this case, this was also treated in this patient. If this was really now the aneurysm responsible for the troponin elevation is not really clear in depth, but this patient had also severe chest pain, so this might have been the case. So as you can see here, we have now, I show you the dedicated coronary CT protocol, and the main difference is that we limit our scan and our to the area of the heart. Of course, it's a gated program, the same way as we did the dual rule-out KV assist. We use KV assist, but the difference is that we use less contrast media. And bolus tracking is also the same. And we usually try to do these scans always with beta blocker and nitroglycerin, just to get the best quality of cardiac imaging which is possible, because here we now have dedicated question to us to rule out CAD, and these patients we do not want to send anymore to the cath lab, only if they need to do intervention. So the whole diagnostics is really done by CT, and also our cardiologists as well as emergency physicians are relying on this imaging of the coronary CT, and therefore we need to have a 100% or nearby 100% accuracy regarding the image quality and the acquisition. And this is nowadays really working very well with standardized protocols. And I just want to finish up with one case here, which is then here a patient, 70-year-old patient presenting with acute chest pain, radiating pain in the left arm for 10 hours in the ER, and short episodes of recurring pain, dizziness, and dyspnea. And the question was CAD or even acute coronary syndrome. So here you can see the reconstructions, and you see again the plugs already. And also in this case, we had them because this was a question of ACS. This patient also went to the cath lab in this one case, and there we could also already saw again what we also discovered in the CT. We had a long segment, 50% stenosis in segment 5 and 6 here. That means the main stem stenosis of 50%. And then in the segment 6, we had also 50% stenosis and also a short segment stenosis of 60% in segment 7. So this is something which need to be treated, and also long segment stenosis, as you can see here again. And I hope I can have now the images in reconstructions with our plug ID. And in the plug ID, you can nicely see what kind of the same segments as we saw in the coronary angiography. So this corresponds very, very nicely. This is also our daily experience that if we do still a coronary angiography, that it mostly matches nicely. And the additional information we can give now to our cardiologists is also the plug analysis of if it's soft plug or hard plug, which is always quite difficult in the coronary angiography. And we also use the same terminology as a cardiologist by the segments. And this is the way you should really communicate with your cardiologist the same way and the same language than they use, and also try to give them some additional information which they do not get from their coronary angiography, invasive coronary angiography, by plug characterization. So let me just conclude. So the chest pain algorithm, the most important first discriminator for optimizing your workflow is the hemodynamic status of the patient. So the decision if the patient is stable or unstable, this is probably the first decision you have to make. An elaborated chest pain algorithm based on the latest ESC guideline and risk scores for all differential diagnosis should be available 24/7. In the emergency department, it is totally senseless that you say, well, I am only providing coronary CT between 8 and 4 o'clock during week times. This is something which definitely needs to be also performed at the weekend. And I think with the technology today, this is also possible. And dedicated CT protocols are, depending on clinical suspicion, need to be developed. I think I tried to show you the algorithm, how we are using it, and we are very strictly following the guidelines. This is the best way how to communicate with your clinical colleagues, and you have less less discussions, and you have clear definitions how you scan your patient. For us, it was quite helpful to have a computer-aided diagnosis software, which is our own development in this case, but it allows us to see the standardized protocols. Of course, you can also draw this in on paper or have the pages from the guidelines available, but I think the best is if you just have this already preserved by a software. Okay, thank you. And now I'm actually looking forward to your questions. So far, questions and answers is still empty on my side here. Therefore, my question to the host, can you provide me with some questions? Okay. So I see more than roughly 30 participants online. So if you still have some questions, please use question and answer. Okay, let's see. One question was, do you always stay at 4 milliliters per second? No, actually 4 milliliters per second we are using for the dual rule out or triple rule out protocol. And for the coronaries, we actually go for 5 milliliters per second. And we usually take 350 or 400 concentration of the contrast media. One of the both. Usually we are taking 400 if available. There's the next question. My question is how long it takes to implement CCTA in chest pain from the first decision in your hospital to the routine practice. Yeah, it took us actually more or less, I would say, 2 years. It has taken, especially, first of all, what I would recommend is with your emergency physician, who is in charge for the emergency department, and your cardiologist to bring them together. And because they are those who are actually referring you the patient. The technique itself is quite straightforward and should no more be a question. But I think the most important thing is that you agree on the pretest probability. But nowadays it's quite helpful. You just have to show them the new guidelines, and especially it was right now our cardiologists who are referring more and more patients for non-invasive coronary angiography, and this is true for the patients from the emergency department as well, from their own wards or from their ambulatory care units. So let's see the next question. Oh yes, there are 2 more. How many radiologists in your department can evaluate stenosis and coronary arteries? Oh, good question. Also at the beginning, it was it's actually my residents who are doing it first. So the reconstruction and the first interpretation is done by the resident, but every report before it goes to the physician should be seen by the attending on call. This is what I recommend. Of course, as this is done in the emergency department, the first impression and the first diagnosis is already transferred from the resident to the emergency physician. But for the report, for the definite report and the final report, it should be always done by the attending. And this can then take 1 or 2 hours. But as I said, in the hemodynamic stable patient, this is not time depending. And you have to see that those patients who come with to rule out CAD on the cardiac unit sometimes stay there for days until they get their invasive angiography. So we are still, even if you have a delay of 3 to 4 hours in between until you have the final report, we are even still much faster in these stable patients than if you have them in the normal workup on the cardiology ward. And then the next question. Oh yeah, it's about GFR. Do you have any restrictions? Also, in this case, we are, after the last recommendations, we are no more that much frightened about this issue. So we are usually, if the clinical decision is clear, we also scan the patient with elevated GFR. Next question. Do you always keep 6-second delay for scan for your, or you just adjust it to a heart rate? Ventricle pump. Oh, so something I don't know actually to answer this way, because me as senior radiologist, this is something really practical, a question which should be then asked to my, but I will definitely go back with you and try to get you an answer later on. And then I have the next question, 4, and then pump. Okay, I think then I have all questions, or is there anything else? Oh yes, one question was, are all techs able to provide this 24/7? Yes, and what was very helpful for us is that we have started very early with our Big 5 protocol. This Big 5 protocol, which I briefly was mentioned in the beginning of my talk, which is an elaborated program for stroke, for the stroke a stroke protocol, which includes the heart, is also a triggered protocol. And therefore, our technicians are quite used to do at least a day 10 to 15 triggered protocols. So this is something where the whole team, in the meantime, is doing it 24/7. And I think nowadays the technology is also became that. I wouldn't say easy, but it's no more that elaborated than before, and it's much easier to learn and to adapt for the technician than it was with the previous versions of the scanner generations, and it's much easier. So this is no more a big problem nowadays. Another question, do you perform one phase scan to minimize dose, or I don't get the rest of the question. One phase scan? Yes, well, that depends. One phase scan, yes, for those who are only getting coronary, the coronary, so our dedicated coronary angiography program, yes, we go for one phase only, also to minimize dose. For triple rule out, we go for all patients for multi-phase program. And there we really do not care so much about the dose, as we already have enlarged the window and also do the whole, usually also try to do the whole aorta, because we also have to rule out aortic syndrome, and therefore the to answer the clinical question is much more important. It is more important to get good image quality in these patients, because we usually don't do them with beta blocker and nitrogen, and therefore we are doing a multi-phase always in triple rule out patients, or dual rule out. Okay, then let's see, is there any more questions? So, yes, I think if there's no more questions to answer, but I still see nearly 30 participants online, so I'm still available. You can still ask questions. Yeah, and so if there's no more questions, or is there one still? But what I would like to announce also is that a replay will be available on the internet, on the page wgecares.com, and there you can see the whole presentation again if necessary. And thank you very much for your attendance, and I hope I gave you some practical informations and hints, and you're able to use the one or the other approach I was presenting to you. Thank you very much, and goodbye and good evening.